Sensation refers to immediate response of the body to stimulation of sensory organs. Now we will see some of the stimulus. First one is distal stimulus. It is called an actual object or event often at a distance, example actual building. Coming to proximal stimulus, it is a pattern of energies that actually impinge an organism, example light patterns, visual image of building on the retina. Proximal stimulus does not possess the same qualities as the distal stimulus. We do not know the thing in itself, we can only know characteristics of the stimulus energize that impinge on the organism. The primitive experiences these stimuli energize create in the organism are called sensations. Example, loudness of tone, sweetness of taste, color. Now coming to the study of sensations. One of the oldest and most distinguished areas of psychology. It is a study of relation between physical characteristics of the stimulus and the psychological experience that result therefrom. Gaston Fechner is often called the father of psychophysics. Fechner's work interested preliminary in intensity of sensation as a function of physical intensity. He argued that sensation cannot be directly compared with physical stimulus intensities, nonetheless they can be directly compared with the another. Subject can compare two of his own sensations and decide whether they are same or different, or whether one is more intense than another. Now coming to the topic senses. We experience reality through our senses. A sense is a faculty by which outside stimuli are perceived. Many neurologists disagree about how many senses that are actually or due to a broad interpretation of the definition of a sense. Our senses are split into two different groups. Our extropstus detects stimulation from the outsiders of our body, for example smell, taste and equilibrium. The interceptors receive stimulation from the inside of our bodies, for instance blood pressure dropping, changes in the glucose and pH levels. Children are generally taught that there are 5 senses, that is sight, hearing, touch, smell and taste. However, it is generally agreed that there are at least 7 different senses in humans and a minimum of 2 more observed in other organisms. Sense can also differ from one person to the next. Take taste for an example. What may taste great to one person will taste awful to someone else. This all has to do with how the brain interprets the stimuli that are received. Now coming to the excellent topic of sensation and perception. Sensation and perception identify processes that differ primarily in their complexity. We have a greater number of senses than is widely believed. Psychophysics is the study of the relationship between physical events and our experience of those events. The absolute threshold is the smallest stimulus that arouses a sensation. The difference threshold is the smallest change in any stimulation that can be detected. The stimulus for vision is light, which has 3 physical characteristics, that is wavelength, intensity and pureness. The psychological attributes are hue, brightness and saturation. Complementary colors as well as other colors may be mixed in an additive or subtractive process. The receptor for vision is the eye, which contains rods for black-white vision and cones for color vision. Vision is the poorest at the blind spot and best at the foveae. Dark adaptation and the Prunski's shift both result from the shift from cone to rod vision. Color blindness affects mainly males, but it is a relatively slight vision problem compared to blindness. The physical stimulus for hearing is pressure waves, which have three physical characteristics, that is frequency, amplitude and complexity. We hear sounds in terms of pitch, loudness and timbre. The receptor for sound is the ear, within which hair cells in the cochlea stimulate the auditory nerve. Two major types of deafness include conduction deafness and nerve deafness. The physical stimuli for the chemical senses are for smell, gas and for taste, liquid. Several systems of basic smells have been proposed with varying degree of success. The four basic tastes are sweet, sour, bitter and salty. The receptor for smell is the nose, and the lock and key theory is the most successful attempt to explain how gases activate our sense of smell. The receptor for taste is the taste buds in the mouth. Specific patterns of taste bud activity seem to be associated with specific tastes. The common cold shows the extent to which smell is the more important of the two chemical senses. The physical stimuli for the skin senses are contact and temperature. They give us a sense of touch, pain, hot and cold. The physical stimuli for the vestibular sense are rotation and the position of the head. These give us our sense of balance. Three semicircular canals and two otolith organs act as receptors. We sense our body position from receptors located in our muscles, tendons and joints. Perception is based on certain factors of organization, including the figure-ground relationship. Another factor is the wholeness of figures, that is determined by symmetry, closure and familiarity. A third is the grouping of elements, that is based on proximity, similarity, continuation and common fate. Three other factors importantly involved in perception include attention, variation in stimulus input and the constancies, that is shape, size, brightness and color. There are two important jobs in visual perception. One is judging distance or depth, which is based on stimuli and cues within the organism. The other is detective motion, which is based on the order in which sensing cells fire and or movement relative to the environment or another object. In perceiving sound, our ability to locate a sound source is based on onset, time, relative loudness and phase differences of the sound waves reaching each ear. Now coming to the next topic, the sense of taste, gustatory system. In humans, the sense of taste is transduced by taste buds and is conveyed via 3 of the 12 cranial nerves. Cranial nerves 7, the facial nerve carries taste sensations from the anterior 2/3 of the tongue, excluding the circumvallatory papillae, see lingual papillae and soft palati. Cranial nerve 9, the glossopharyngeal nerve carries taste sensation from the posterior one-third of the tongue, including the circumvallatory papillae. Also, a branch of vagus nerve carries some taste sensation from the back of the oral cavity, that is pharynx and epiglottis. Information from these cranial nerves is processed by the gustatory system. Though there are small differences in sensation which can be measured with highly specific instruments, all taste buds can respond to all types of taste. Sensitivity to all tastes is distributed across the whole tongue and indeed to other regions of the mouth where there are taste buds. Coming to papilla. Papilla are specialized epithelial cells. There are four types of papilla: filiform, fungiform, foliate and circumvallatory. All papilla except the filiform have taste buds on their surface. Some act directly by ion canals, other acts indirectly. Fungiform papillae, as the name suggests, are slightly mushroom shaped if looked at it section. These are present mostly at the apex of the tongue, that is at the tip of the tongue. Filiform papillae, these are thin, longer papillae that do not contain taste buds but are the most numerous. These papillae are mechanical and not involved in gustation. Foliate papillae, these are ridges and grooves towards the posterior part of the tongue. Coming to circumvallatory papillae, there are only about 3 to 14 of these papillae on most people and they are present at the back of the oral part of the tongue. They are arranged in a circular shaped row just in front of the sulcus terminalis of the tongue. Now coming to types of taste. The first one is salt. Arguably the simplest receptor found in the mouth is the salt, that is also called as NaCl receptor. An ion canal in the taste cell wall allows Na plus ions to enter the cell. This ion its own depolarizes the cell and opens voltage regulated Ca2 plus gates, flooding the cell with ions and leading to neurotransmitter release. This sodium canal is known as ENaC and is composed of 3 subunits. ENaC can be blocked by the drug amiloride in many mammals, especially rats. The sensitivity of the salt taste to amiloride in humans, however, is much less pronounced, leading to conjecture that there may be additional receptor proteins besides ENaC that may not have been discovered yet. Now coming to sour. Sour taste signals the presence of acidic components H plus ions in solution. There are 3 different receptors proteins at work in sour taste. The first is a simple ion channel which allows hydrogen ions to flow directly into the cell. The protein for this is ENaC, the same protein involved in the distinction of salt taste. This implies a relationship between salt and sour receptors and could explain why salty taste is reduced when a sour taste is present. There are also H plus gated canals present. The first is a K plus canal which ordinarily allows K plus ions to escape from the cell. H plus ions block this, trapping the potassium ions inside the cell. This receptor is classified as MDEGI of the ENaC DEC family. The third protein opens to Na plus ions when a hydrogen ion attaches to it, allowing the sodium ions to flow down the concentration gradient into the cell. The influx of ions leads to the opening of the voltage regulated Ca2 plus gate. These receptors work together and lead to depolarization of the cell and neurotransmitter release. Now coming to bitter. There are many classes of bitter compounds which can be chemically very different. It is interesting that the human body has evolved a very sophisticated sense for bitter substances. We can distinguish between the many radically different compounds which produce a generally bitter response. This may be because the sense of bitter taste is so important to survival, as ingesting a bitter compound may lead to injury or death. Bitter compounds act through structures in the taste cells, walls called G protein coupled receptors. It is also called as GPCRS. Recently, a new group of GPCRS was discovered, known as the T2RS, which is thought to only respond to bitter stimuli. When the bitter compound activates the GPCR, it in turn realizes gustacin, the G protein it was coupled to. Gustacin is made of 3 subunits. When it is activated by the GPCR, its subunits break apart and activate phosphodiesterase, a nearby enzyme. It then converts a precursor within the cell into a secondary messenger which closes potassium ion canals. This secondary messenger can stimulate the endoplasmic reticulum to realize Ca2+, which contributes to depolarization. This leads to a buildup of potassium ions in the cell, depolarization and neurotransmitter release. It is also possible for some bitter tastans to indirectly with the G minus protein because of a structural similarity to the relevant GPCR. Next is sweet. Like bitter taste, sweet taste transduction involves GPCRS. The specific mechanism depends on the specific molecule. Natural sweeteners such as saccharides activates the GPCR, which realizes gustacin. The gustacin then activates the molecule aldolate cyclase, which is already inside the cell. This molecule increases concentration of the molecule CAMP or adenosine 3' 5' to cyclic monophosphate. This protein will either directly or indirectly close potassium ion canals, leading to depolarization and neurotransmitter release. Synthetic sweeteners such as saccharin activate different GPCRs, initiating a similar process of protein transitions, starting with the protein phospholipase A, which ultimately leads to the blocking of potassium ion canals. Coming to umami. Umami is a Japanese word meaning savory or meaty. It is thought that umami receptors act much the same way as bitter and sweet receptors, but not much is known about their specific function. We do know that umami defects glutamates that are common in meats, cheese and other protein heavy foods. Umami receptors react to foods treated with monosodium glutamate MSG. This explains why eating foods that have MSG in them often gives a sense of fullness. It is thought that the amino acid L-glutamate bonds to a type of GPCR known as the metabotric glutamate receptor. This causes the G protein complex to activate a secondary receptor, which ultimately leads to neurotransmitter release. The intermediate steps are not known. Now coming to disorders of the tongue. Loss of taste. You may lose your sense of taste if the facial nerve is damaged. Then there is also Sjogren syndrome, where the saliva production is reduced. In most cases, the loss of taste is typically a symptom of anosmia, a loss of sense of smell. Sore tongue. It is usually caused by some form of trauma such as biting your tongue or eating piping hot or highly acidic food or drink. If your top and bottom teeth do not fit neatly together, tongue trauma is more likely. Some people may experience a sore tongue from grinding their teeth, that is called as bruxism. Disorders such as diabetes, anemia, some types of vitamin deficiency and certain skin disease can include a sore tongue among the range of symptoms. Glossidynia, a condition categorized by a burning sensation on the tongue. Benign migratory glossitis. This condition is characterized by irregular and inflamed patches on the tongue surface that often have white borders. Tongue may be generally swollen, red and sore. Another name for this condition is geographic tongue. The cause of benign migratory glossitis is unknown. Risk factors are thought to include mineral or vitamin deficiencies, local irritants such as strong mouthwashes, cigarettes or alcohol, certain forms of anemia, infection, certain medications, stress. The sense of smell. Olfactory system. Olfaction is the sense of smell. In human, the sense of smell is received in nasopharynx. Airborne molecules go into solution on moist epithelial surface of nasal passage. An olfactory receptor's neuron sends an impulse via cranial nerve, that is the olfactory nerve. Although 80 to 90% of what we think is taste actually is due to smell. This is why when we have a head cold or stuffed up nose, we have harder time tasting our foods. Receptors. Humans have 347 functional odor receptor genes. The other genes have nonsense mutations. This number was determined by analyzing the genome in the Human Genome Project. The number may vary among ethnic groups and does vary among individuals. For example, not all people can smell androstenone, a component of male sweat. Each olfactory receptor neuron in the nose expresses only one functional odor receptor. Odor receptor nerve cells may function like a key lock system. If the odor molecules can fit into the lock, the nerve cell will respond. According to shape theory, each receptor detects a feature of the odor molecule. Weak shape theory, known as odotope theory, suggests that different receptors detect only small pieces of molecules and these minimal inputs are combined to create a larger olfactory perception, similar to the way visual perception is built up of smaller information poor sensations combined and refined to create a detailed overall perception. An alternative theory, the vibration theory proposed by Luca Turnin, posits that odor receptors detect the frequencies of vibration of odor molecules in the infrared range by electron tunneling. An olfactory receptor neuron, also called an olfactory sensory neuron, is the primary transduction cell in the olfactory systems. Humans have about 40 million olfactory receptor neurons. In vertebrates, olfactory receptor neuron resides on the olfactory epithelium in the nasal cavity. These cells are bipolar neurons with a dendrite facing the interior space of the nasal cavity and an axon that travels along the olfactory nerve to the olfactory bulb. Disorders of olfaction. Anosmia. Anosmia is the lack of olfaction or a loss of sense of smell. It can be either temporary or permanent. A related term, hyposmia, refers to a decrease in the ability to smell. Some people may be anosmic for one particular order. This is called specific anosmia and may be genetically based. Anosmia can have a number of detrimental effects. Patients with anosmia may find food less appetizing. Loss of smell can also be dangerous because it hinders the detection of gas leaks, fire, body odor and spoiled food. The common view of anosmia as trivial can make it more difficult for a patient to receive the same types of medical aid as someone who has lost other senses such as hearing or sight. A temporary loss of smell can be caused by a stuffy nose or infection. In contrast, a permanent loss of smell may be caused by death of olfactory receptor neurons in the nose or by brain injury in which there is damage to the olfactory nerve or damage to brain areas that process smell. Phantosmia. Phantosmia is the phenomenon of smelling odors that are not really present. The most common odors are unpleasant smells such as rotting flesh, vomit, feces, smoke and so on. Phantosmia often results from damage to the nerve tissue in the olfactory system. The damage can be caused by viral infection, trauma, surgery and possibly exposure to toxins or drugs. It can also be induced by epilepsy affecting the olfactory cortex. It is also thought that the condition can have psychiatric origins. Dysosmia, when things smell differently than they should. The sense of vision. Vision needs to have the work of both eyes and the brain to process any information. The majority of the stimuli is done in the eyes and then the information is sent to the brain by the way of nerve impulses. At least 1/3 of the information of what the eye sees is processed in the cerebral cortex of the brain. Anatomy of the eye. The human eye is an elongated ball about 1 inch in diameter and is protected by a bony socket in the skull. The eye has 3 layers or coats that make up the exterior wall of the eyeball, which are the sclera, choroid and retina. Sclera. The outer layer of the eye is the sclera, which is a taut white fibrous layer that maintains, protects and supports the shape of the eye. The front of the sclera is transparent and is called the cornea. The cornea refracts light rays and acts like the outer window of the eye. Choroid. The middle thin layer of the eye is the choroid, also known as choroidea or choroid coat. It is the vascular layer of the eye lying between the retina and the sclera. The choroid provides oxygen and nourishment to the outer layer of the retina. It also contains a non-reflective pigment that acts as a light shield and prevents light from scattering. Coming to retina, the third or the innermost layer of the eye is called the retina. In adult humans, the entire retina is 72% of a sphere about 22 mm in diameter. The retina lays over the back 2/3 of the choroid coat, which is located in the posterior compartment. The compartment is filled with vitreous humor, which is a clear gelatinous material. Within the retina, there are cells called rod cells and cone cells, also known as photoreceptors. Eye movement. The visual system in the brain is too slow to process that information if the images are slipping across the retina at more than a few degrees per second. Thus, for humans to be able to see while moving, the brain must compensate for the motion of the head by turning the eyes. To get a clear view of the world, the brain must turn the eyes so that the image of the object of regard falls on the fova. Eye movements are thus very important for visual perception, and any failure to make them correctly can lead to serious visual disabilities. Having two eyes is an added complication because the brain must point both of them accurately enough that the object of the regard falls on corresponding points of the two retinas, otherwise double vision would occur. The movements of the different body parts are controlled by striated muscles acting around joints. The movements of the eye are no exception, but they have special advantage not shared by skeletal muscles and joints, and so are considerably different. Disease, disorders and age related changes. There are many disease, disorders and age related changes that may affect the eyes and surrounding structures. As the eye ages, certain changes occur that can be attributed solely to the aging process. Most of this anatomic and psychologic process follow a gradual decline. With aging, the quality of vision worsens due to reasons independent of aging eye diseases. Color blindness. Color blindness or color vision deficiency in humans is the inability to perceive differences between some or all colors that other people can distinguish. It is most often of genetic nature but may also occur because of eye, nerve or brain damage or due to exposure to certain chemicals. There are many types of color blindness. The most common variety is hereditary photoreceptor disorders, but it is also possible to acquire color blindness through damage to the retina, optic nerve or higher brain areas. There is generally no treatment to cure color deficiency. However, certain types of tinted filters and contact lenses may help an individual to distinguish different colors better. Night blindness, it is also known as nyctalophia, is a condition making it difficult or impossible to see in the dark. It is a symptom of several eye diseases. Night blindness may exist from birth or be caused by injury or malnutrition. The most common cause of nyctalophia is retinitis pigmentosa, a disorder in which the rod cells in the retina gradually lose their ability to respond to the light. Day blindness, it is also known as hemerolophia, is the inability to see clearly in bright light. The daytime vision gets worse and worse. Nighttime vision remains unchanged due to the use of rods as opposed to cones, which get affected by hemerolophia and in turn degrade the daytime optical response. Floater, also known as musky volitantus, or deposits of various size, shape, consistency, refractive index and motility within the eyes, normally transparent vitreous humor. Floaters are suspended in the vitreous humor, the thick fluid or gel that fills the eye. Thus, they generally follow the rapid motions of the eye while drifting slowly within the fluid. Floaters are visible only because they do not remain perfectly fixed within the eye. The shapes or shadows projected onto the retina by tiny structures of protein or other cell debris discarded over the years and trapped in the vitreous humor. Now coming to glaucoma, a group of diseases of the optic nerve involving loss of retinal ganglion cells in a characteristic pattern of optic neuropathy. Although raised intraocular pressure is a significant risk factor for developing glaucoma, there is no set threshold for intraocular pressure that causes glaucoma. One person may develop nerve damage at a relatively low pressure while another person may have high eye pressures for years and yet never develop damage. Coming to visual agnosia. Visual agnosia is the inability of the brain to make sense of or make use of some part of otherwise normal visual stimulus and is typified by the inability to recognize familiar objects or faces. This is distinct from blindness, which is a lack of sensory input to the brain due to the damage to the eye or optic nerve. The sense of hearing. The ear is a sense organ that collects and detects sound waves and plays a major role in the sense of balance and body position. The sensory receptor for both hearing and equilibrium or mechanoreceptors found in the inner ear. These receptors are hair cells that have stereocilia that are extremely sensitive to mechanical stimulations. Anatomy of the ear. The ear has three divisions: the outer ear, the middle ear and the inner ear. Anatomy of the human ear: outer ear, auricle, ear canal, surface of the eardrum. The outer ear is the most external portion of the ear. The outer ear includes the pinna. It is also called as auricle, the ear canal and the very most superficial layer of the eardrum. Although the word ear may properly refer to the pinna, covered cartilage appendage on either this portion of the ear is not vital for hearing. The complicated design of the human outer ear does help capture sound, but the most important functional aspect of the human outer ear is the ear canal itself. This outer ear canal skin is applied to the cartilage. The thinner skin of the deep canal lies on the bone of the skull. If the ear canal is not open, hearing will be dampened. Ear wax is produced by the glands in the skin of the outer portion of the ear canal. Only the thicker cerumen producing the ear canal skin has hairs. The outer ear ends at the most superficial layer of the tympanic membranes. The tympanic membranes is commonly called the eardrum. Now coming to middle ear. The middle ear includes most of the eardrum and the three ear bones: ossils, malicus, incus and stapes. The opening of the eustachian tube is also within the middle ear. Now coming to inner ear. The inner ear includes both the organs of hearing and a sense organ that is attend to the effects of both gravity and motion. The balanced portion of the inner ear consists of three semicircular canals and the vestibule. The inner ear is encased in the hardest bone of the body. Within this ivory hard bone, there are fluid filled hollows. Within the cochleae are three filled fluid spaces: the tympanic canal, the vestibular canal and the middle canal. The 8th cranial nerve comes from the brain stem to enter the inner ear. Process of hearing. Detection of sound motion is associated with the right posterior superior temporal gyrus. The superior temporal gyrus contains several important structures of the brain, including marking the location of the primary auditory cortex, the cortical region responsible for the sensation of sound. A section 41 and 42 are called the primary auditory area of the cerebrum and they process the basic characteristics of sound such as pitch and the rhythm. The auditory association area is located within the temporal lobe of the brain in an area called the Wernicke's area or area 22. This area near the lateral cerebral sulcus is an important region for the processing of acoustic energy so that it can be distinguished as speech, music or noise. It also interprets words that are heard into an associated thought pattern of understanding. The gnostic area of the cerebrum helps to integrate all incoming sense patterns so that a common thought can be formed using all arriving sensory information. The sense of touch. Touch is the first sense developed in the womb and the last sense used before death. With 50 touch receptors for every square centimeter and about 5 million sensory cells overall, The skin is very sensitive and is the largest and one of the most complex organs in our bodies. These touch receptors are grouped by type and include mechanoreceptors, thermoreceptors and nociceptors. Pacinian corpuscles. Sodium ion channels in the axon membrane. This allows sodium ions to influx in, creating a Pacinian corpuscles, detect gross pressure changes and vibrations. They are the largest of the receptors. Any deformation in the corpuscle causes action potentials to be generated by opening pressure sensitive receptor potential. Pacinian corpuscles cause action potentials when the skin is rapidly intended but not when the pressure is steady due to the layers of connective tissue that cover the nerve ending. It is thought that they respond to high velocity changes in joint position. Mesonous corpuscle. Mesonous corpuscle are distributed throughout the skin but concentrated in areas especially sensitive to light touch such as fingertips, palms, soles, lips, tongue, face, nipples and the external skin of the male and female genitals. They are primarily located just beneath the epidermis within the dermal papillae. Merkel discs. Merkel discs are mechanoreceptors, making them sensitive to pressure and vibration. In humans, Merkel cells occur in the superficial skin layers and are found clustered beneath the ridges of the fingertips that make up fingerprints. They are somewhat rigid in structure and the fact that they are not encapsulated causes them to have a sustained response to mechanical deflection of the tissue. Ruffin corpuscles. Ruffin corpuscles are thermoreceptors aiding in the detection of temperature changes. Named after Angela Ruffina, the Ruffini ending is a class of slowly adapting mechanoreceptor throughout to exist only in the glabrous dermis and subcutaneous tissues of humans. This spindle shaped receptor is sensitive to skin stretch and contributes to kinesthetic sense of and control of finger position and movement. Disorders of touch. Sensory processing disorder. In most people, sensory integration occurs naturally without a thought process. But in some people, the sensory integration does not develop properly and becomes distorted. In these people, the brain and central nervous system misinterprets everyday sensory information such as touch, sound and movement. Research is still being done on this disorder, but they are finding direct links to SPD with other disorders like premature birth, autism, Down syndrome and Fragile X. Now coming to tactile defensiveness. Considered a category of SPD, tactile defensiveness is an overreaction to the sense of touch. Identified by Dr. John Ayers in 1960s. A person with tactile defensiveness will react with a flight or fight reaction to touch stimuli that a normal person would interrupt as harmless. Most cases are noticed in children or babies due to the fact that they do not want to be touched or cuddled as a normal child would. A child with this disorder will probably have this sign or symptoms. They does not like to go barefoot or have feet touched. They does not enjoy baths, haircuts, nail clipping. They always requires tags to be removed from all clothing. They does not want their face touched and they feel hard time eating because of textures, temperatures of the food. They does not want to touch anything that is messy or has a sticky texture. Now coming to the conclusion, so far we have discussed about sensation, senses sensation and perception, the five senses and its disorder. Finally, I want to conclude that this sensation is applied in Montessori method of sensory training. I hope you all enjoyed this session. Thank you viewers.